Welcome to City Vision University's podcast, providing book summaries of books on rescue missions, city missions, and the Salvation Army. Imagine, for just a moment, that you live in a city where 10% of the population is just systematically allowed to consume over 50% of the municipality's entire emergency budget.
Yeah, you would probably think the system was completely rigged or, totally broken.
Right, or like the victim of some massive accounting error or something.
Exactly.
But the thing is, that isn't a hypothetical thought experiment. That is literally exactly how the economics of municipal resources for homelessness actually function in a lot of places today.
It is a staggering mathematical reality. And it fundamentally challenges how we think about social safety nets.
Probably.
Because it forces us to reconsider emergency response and, community care as a whole.
So today, for our deep dive, we are going deep into the invisible ecosystem that sort of surrounds this crisis.
Right. We're pulling apart a really foundational academic paper.
Yeah, it's from the journal Family and Community Health. It was published back in 2009 by Ben Graybase.
And it's titled Faith-Based Programs and Their Influence on Homelessness.
Yes. And our mission today for this deep dive is, it's pretty ambitious. We are going to dissect the staggering economics of chronic homelessness.
We really are. We're going to look at the invisible architecture of those community safety nets.
And I think most importantly, we want to explore how these interventions actually function on the ground, like in real time, when federal systems just fail.
Yeah, because the solution, or at least, the most viable attempt at a solution, it often lies in this incredibly unlikely partnership.
Oh, absolutely.
We are talking about the intersection between massive, slow-moving federal policy and these hyper-local, fast-acting, faith-based street ministries.
Okay, let's unpack this for a second, because before we can even look at the crisis of homelessness itself or, the interventions, we really have to look at the fuel.
The fuel, right.
Yeah, like the resource engine that actually powers these frontline organizations, because reading the source material, the numbers regarding American generosity are honestly they are difficult to wrap your head around.
They completely dwarf most public perceptions of how social services are funded. They really do.
Yeah.
Because when we talk about safety nets, our minds almost automatically go to taxation.
Oh, sure. You think of government budgets, city councils allocating funds, federal grants, that kind of thing.
Right, exactly. But this research, it forces us to look at a completely different, totally decentralized pool of capital.
Private philanthropy.
Yes, private philanthropy.
So BASE brings in this data from a November 2006 comparison. It was conducted by the Charities Aid Foundation. And let me just lay out the global contrast here, because it really sets the stage for everything else we're going to talk about today.
It's pretty wild.
It is. So in 2006, the United States gave 1.7% of its gross domestic product to charity.
Which is just an astronomical metric if you understand GDP.
It really is. It translates to an estimated $295.02 billion.
Wow.
Let's just sit with that number for a second. Over $250 billion given voluntarily in a single year.
Yeah, and just to contextualize that globally, the U.S. ranked number one by a massive, massive margin.
Right, because number two was Britain, and they gave 0.73% of their GDP.
So literally less than half the rate of the United States.
Exactly. And then France trailed way, way behind at 0.14%.
What's fascinating here is how that money is actually generated too.
How do you mean?
Well, it's not just a handful of billionaires setting up these mega foundations to dodge taxes, which is, that's often the cynical assumption people make.
Right.
The data actually shows that 60% of all American households participated in this philanthropic output.
60%, that's a huge majority.
Yeah, and the average giving was about $2,000 per household.
Wow. Okay, so you have this incredibly broad base of everyday citizens just casually funding a $250 billion industry. And here is the crucial piece of the puzzle for our specific deep dive today. Nearly a third of all those donations, almost 33%, which equates to $96.82 billion, went directly to religious organizations.
Almost $100 billion specifically earmarked for faith-based and religious institutions.
Right. I look at that $295 billion and specifically that $96 billion going to religious groups, and I can really only describe it as a shadow national budget.
A shadow budget, I like that.
Yeah, it is this massive, decentralized, citizen-directed pool of capital, and it operates entirely parallel to the federal government. But I have to push back here. I really do.
Okay, let's hear it.
Because this is the paradox that absolutely drives me crazy.
Go for it.
If we as a society have this shadow budget, if everyday citizens are willingly throwing nearly $300 billion at charitable causes in a single year, and nearly $100 billion of that is going to religious groups who run these community missions, why on earth is homelessness still so incredibly visible?
It's a fair question.
Right. Like, why is the crisis getting worse in so many urban centers? Is money alone just not the answer? Because if it were purely a capital problem, $250 billion a year should have eradicated it entirely, shouldn't it? Where is the disconnect?
That is exactly the right question to ask.
Mm.
And the answer requires us to really look at the systemic architecture of how different nations handle social welfare.
Okay.
In those European nations you mentioned earlier, France, Britain, there is a heavy, almost exclusive reliance on state-run, tax-funded social programs.
Got it.
The government is the primary and literally the only authorized actor in the social safety net. So if someone falls on hard times, they go to a government office, they interface with the government caseworker, and they receive government funds.
So it's a completely centralized model.
Exactly. But the American model is structurally unique. Historically, culturally, systemically, the U.S. government essentially delegates a massive portion of its frontline social work to local non-governmental organizations.
And very frequently, those are faith-based organizations.
Precisely. It is a symbiotic relationship. The source material points out that this integration government support, relying heavily on localized faith-based infrastructure, it's unlike anywhere else in the developed world. And it isn't just about saving the government money on everyday operations either. It is really about agility and responsiveness.
Oh, right. The paper brings up disaster relief to illustrate this, specifically mentioning Hurricane Katrina and the devastating 2004 tsunami.
Yes, think about the logistics of a massive natural disaster. When Katrina hit, the federal government, FEMA, the military they obviously deployed.
Sure.
But federal bureaucracy is inherently slow, requires chains of command, massive logistical staging, appropriations from Congress.
It takes time.
Right.
Yeah.
The paper notes that Americans didn't wait for the federal response. They immediately stepped up with their time, their talent, and their treasure.
Right. It was like local church groups loading up pickup trucks with bottled water and driving down to Louisiana the very next morning.
Exactly. These philanthropic networks, especially the faith-based ones, proved they have an unmatched capability for immediate deployment.
Because they're already there.
Exactly. They don't need an act of Congress to open their doors or start distributing supplies. They're embedded in the community, and they react instantly.
Wow. Yeah.
That exact same agility, that same localized response mechanism is what the overall system relies on to address the daily chronic disaster of homelessness.
So we have established that this massive pool of capital exists, right? And that the U.S. relies on this decentralized agile network to deploy it, which brings us to a really intense strategic debate in the source material.
It's a huge debate.
Yeah. If the government and these local organizations are working together, how do they actually agree on how the money should be spent to fix the problem? What is the actual philosophy of intervention?
And this is where the policy wonks and the street-level providers often clash pretty hard.
I bet.
The U.S. Department of Housing and Urban Development, HUD, essentially operates around two core competing philosophies for addressing and funding these homelessness interventions.
Okay, let's unpack these. The first strategy is called the continuum of care.
Right, continuum of care. It's historically the more traditional approach. The underlying philosophy here is that you must wrap corrective services around the individual first before you ever offer them permanent housing.
Meaning you address the root causes of their instability.
Yes.
You put them in a temporary shelter, sure,
Yeah.
but the focus is on mandatory engagement.
Yeah.
You require them to attend substance abuse rehabilitation. You enroll them in job training programs. You initiate mental health treatments and, ensure they are medication compliant.
Right. The logic is that homelessness is usually a symptom of deeper systemic issues within the individual.
Okay.
So if you don't treat the addiction or the untreated schizophrenia first, simply giving them a set of keys to an apartment is a recipe for failure. Under continuum of care, permanent housing is viewed almost as a graduation present.
A graduation present. Wow.
Yeah, you essentially earn your way into stability by proving you can manage the underlying issues.
Okay. But the second strategy, which the paper notes has gained massive, massive traction, flips that entire script upside down. It is called housing first.
Housing first is exactly what it sounds like. The core tenet is that housing is a fundamental human right, not a reward for clinical compliance.
Right.
So under this philosophy, You get the person into a stable, permanent home immediately, right off the street. You do this regardless of their current personal challenges, regardless of their employment status, and crucially, regardless of their sobriety.
You house them first, and then you deal with the rest of the trauma.
Yes. The psychological argument here is based on stability. Advocates for housing first argue that it is practically impossible for a human being to successfully battle a severe heroin addiction or manage complex bipolar disorder while they are sleeping under a concrete overpass or constantly moving between dangerous temporary shelters.
I mean, that makes total sense. It's the ultimate chicken or the egg debate. Do you fix a person's underlying problem so they have the capacity to maintain a home? Or do you give them a home so they have the foundational stability required to actually focus on fixing their problems?
It is a profound philosophical division. And the author of our source material acknowledges that there's highly compelling data and convincing arguments for both positions.
Yeah.
But to understand how faith-based organizations actually navigate this divide on the ground, the paper introduces a really helpful analogy. It compares the necessary community support system for addressing homelessness to a three-legged stool.
A three-legged stool. Okay, I like analogies. Let's break down the mechanics of this stool. What are the three legs required to keep a person off the street permanently?
Okay, so leg number 1 is alcohol and drug recovery services.
Leg 1, got it.
Leg number 2 is mental health services. And leg number 3 is the physical housing itself.
And the structural reality of a stool, obviously, is that it absolutely cannot stand on one leg. It can't even stand on two.
Precisely. Let's look at how this applies to the HUD philosophies. If you lean entirely into the housing first model, and you only provide the third leg, the permanent apartment, but the individual has severe untreated trauma, chemical dependency, and no coping mechanisms, the stool falls over.
Yeah, they inevitably violate the terms of their lease, or they cause disturbances, or they just abandon the property. They lose the housing.
Exactly. And conversely, if you only focus on the continuum of care, if you provide intense recovery programs and mental health counseling, which are legs 1 and 2, but at the end of the day, the person has to take their newly sober, deeply vulnerable self and go sleep in a tent encampment, the stool falls over again.
Because the environmental stress just triggers a relapse.
Exactly. What this academic paper so effectively argues is that faith-based providers are the undisputed master craftsmen of those first 2 legs.
Wow. They are the ones actually out there in the trenches doing the grueling, unglamorous day-to-day work of alcohol rehabilitation, drug recovery, and mental health support.
Right. They are not typically the entities building the massive apartment complexes, but they are preparing the individual. They are stabilizing the human being, building up their resilience and capacity so that when leg 3, the permanent housing funded by HUD or local government, is finally introduced, the stool is structurally sound.
It can actually stand on its own.
Exactly.
To really understand why that three-legged stool is so absolutely critical and why building those first 2 legs is so incredibly difficult, we have to take a hard look at who exactly is experiencing homelessness.
Yeah, we do.
Because reading this research, one thing becomes immediately undeniably clear. The homeless population is not a monolith.
Not even remotely.
Yeah.
And designing sweeping public policy as if they are a monolith is exactly where so many municipal governments fail spectacularly.
Right.
The source gives us a very clear demographic breakdown that we really need to understand. The vast majority of people experiencing homelessness fall into a category the paper defines as the transitionally homeless.
Transitionally homeless, meaning their time on the streets or in a shelter is strictly temporary.
Yes. Now, since you, the listener, are likely well-versed in social dynamics, we don't need to spend an hour explaining the basic mechanics of poverty. We all understand how a sudden medical bankruptcy, an unexpected eviction notice, or, escaping a domestic violence situation can abruptly force someone out of their housing.
Right. The transitionally homeless are often just caught in an acute financial or situational crisis. They utilize the safety net, maybe staying in a shelter for a few weeks or months. They get back on their feet and they exit the system.
Yes.
The paper even notes that intact families make up 24% of families in shelters.
Which is huge.
It really shatters the outdated stereotype of the isolated, wandering vagrant. We're talking about a quarter of the family's shelter population being mothers, fathers, children, just trying to weather a severe temporary economic storm.
Yeah, they are the majority in terms of sheer numbers.
Yeah.
But they are not the population that strains the system to its breaking point.
Yep.
To understand the economics of this crisis, you have to look at the other extreme of the spectrum. Roughly 10% of the homeless population in the United States at any given time is categorized as chronically homeless.
Just 10%.
Just 10.
That is a remarkably small slice of the overall pie.
A tiny fraction, statistically speaking. But they are, by magnitudes, the most complex and difficult population to serve. And more importantly, for our systemic analysis today, they consume an almost unbelievable proportion of municipal resources.
Right.
The paper relies heavily on landmark research conducted by Dennis Culhane at the University of Pennsylvania, which began back in the late 1990s.
Okay.
Culhane isolated this small 10% cohort and tracked their systemic footprint. And he found that they don't just use shelters temporarily. They cycle endlessly, year after year, through long-term shelter stays, emergency rooms, psychiatric hospitals, county jails, and municipal detox programs.
And this brings us right back to that hook, the statistic that absolutely stopped me in my tracks when I first read it. Culhane's research revealed that this tiny 10% of the population utilizes more than 50% of a given community's emergency shelter resources.
10% of the people consuming over 50% of the resources. It is a massive systemic structural imbalance.
I really want to do a deep analysis of the financial toll here. I want to look at the mechanics of how that money is actually being burned, because the paper provides some specific case studies that are just impossible to ignore.
Yeah, let's look at them.
Okay, let's look at the study from the Boston Healthcare for the Homeless program. They decided to track the actual literal medical expenses of just 119 chronically homeless individuals over the course of 5 years.
Before we get to the money, though, we have to acknowledge the staggering human toll of that Boston study.
Yeah, absolutely.
Over those 5 years, out of that small cohort of 119 people, 33 of them died on the streets.
Wow.
7 more deteriorated so severely they were institutionalized in nursing homes.
That is a devastating mortality rate, 33 out of 119.
That's horrific.
But let's look at the systemic strain caused by the survivors, too. That same small group, essentially 100 people, accounted for 18,834 emergency department visits over 5 years.
Let's actually do the math on that to understand the velocity of this system failure.
Okay, 18,834 visits divided by roughly 119 people. That means, on average, each one of these individuals was going to the emergency room 158 times over 5 years.
That's incredible.
It is. That is more than 31 ER visits a year per person. They are utilizing a trauma center as a primary care clinic almost 3 times a month, and the paper states that those emergency room visits cost a minimum of $1,000 each.
And realistically, in today's healthcare economy, it's far more than $1,000.
Exactly. But even using their conservative baseline, that is nearly $19 million. $19 million spent purely on emergency room intake for barely over 100 people.
And Boston is not an anomaly. The paper also points to a landmark systemic study in New York City. This one focused specifically on homeless individuals diagnosed with serious mental illness. They calculated the aggregate public funds spent on these individuals.
And what did they find?
They found that on average, each homeless person in that specific category utilized more than $40,000 annually in publicly funded services.
$40,000.
Yep. We are talking about the combined costs of municipal shelters, Veterans Affairs hospitals, emergency departments, state prisons, and outpatient psychiatric care.
And let's be super clear about where that $40,000 was actually going. It wasn't going to housing. It wasn't providing stability.
Not at all.
The bulk of that massive annual expenditure was going to psychiatric hospitalization. The data showed an average of more than 57 days spent in a psychiatric facility per person, which cost taxpayers nearly $13,000 right off the top.
Now, this is where the economic argument for intervention becomes absolutely bulletproof. Compare that chaotic, reactive $40,000 annual burn rate to the cost of a permanent solution.
Mm-hmm.
The paper details the municipal savings generated when these exact same high utilizer individuals are finally placed in permanent supportive housing. In New York, when they house these individuals, the public costs declined by $16,282 per person per year.
Wow.
Yeah, that reduction in emergency service usage generated savings that were nearly enough to pay for the supportive housing unit itself.
The numbers really do validate this approach across the entire country. The paper cites the Denver Housing First Collaborative, too. By moving the chronically homeless into stable units, they reduced public emergency costs by $15,773 per person annually.
And get this, it only cost them $13,400 to actually house the person.
Wait, really?
Yes. So the city actually made money by solving the problem.
That's wild. And in Cortland, Oregon, their community engagement program tracked similar metrics. They reduced combined healthcare and incarceration costs from over $42,000 a year down to roughly $17,000. After paying for the entire supportive program, the city of Portland generated a net savings to the taxpayer of $15,006 per person in the very first year alone.
The conclusion is inescapable. It is empirically, objectively, and mathematically cheaper to give a chronically homeless person a permanent supported apartment than it is to abandon them on the street to cycle through trauma centers and holding cells.
I have to pause here, though.
Okay.
Because I have a very strong, somewhat conflicting reaction to this entire section of the source material.
Why is that?
Well, I understand the math. The logic is flawless, but it feels incredibly clinical, almost alarmingly cold.
I could see that.
We are looking at profound human tragedy. We just talked about 33 human beings dying on the concrete in Boston, and we are framing their existence as a line item on a municipal balance sheet. We are literally justifying saving human lives by pointing out to city councils that emergency room visits are getting a bit too expensive.
I hear you. But if we connect this to the bigger picture of how society actually functions, you have to look at the harsh reality of public policy making.
Right.
Framing human dignity in stark economic terms is sometimes the only functional lever advocates have to force systemic change.
So it's like a Trojan horse for compassion.
Exactly.
Yeah.
Municipalities operate on incredibly tight, heavily scrutinized budgets. Taxpayers are fiercely protective of their money, and they demand efficiency.
Sure.
If a social worker or an advocate walks into a city council meeting and appeals entirely to morality, if they just talk about the tragedy of those 33 deaths, they might get sympathetic nods from the council members. They might get a nice quote in the local paper, but they rarely get the multi-million-dollar funding appropriations required to build supportive housing.
But sympathy doesn't balance the municipal budget.
Right. But by walking into that exact same room with Culthean's data, by proving with hard, clinical, peer-reviewed math that housing people is actually cheaper for the taxpayer than letting them endlessly utilize police resources and trauma centers, advocates can secure the actual dollars needed to build the facilities.
Okay.
The cold clinical data is the key required to unlock the compassionate, life-saving outcome.
Okay. It is a pragmatic necessity. I see the mechanism there. So having established this macroeconomic view, we've looked at the massive national philanthropy stats, the deep HUD philosophies, the heavy data from New York and Boston. We really need to see how this actually works.
Right.
We need to see where the federal math breaks down at the street level. And to do that, the source material focuses heavily on a very specific environment, El Paso, Texas.
El Paso is a highly revealing microcosm.
How so?
Well, because of its location right on the U.S.-Mexico border, it deals with unique transnational pressures. Yet the macro-national trends we just discussed hold remarkably true there. The rate of chronically homeless people in El Paso fluctuates right around that exact 10% mark we've been analyzing.
The paper references a really specific data set, a 2005 point-in-time survey conducted by the El Paso Coalition for the Homeless. For those unfamiliar, a point-in-time survey is exactly what it sounds like. On a single designated night, outreach workers fan out across the city and attempt to physically count and survey every single sheltered and unsheltered homeless person they can find.
Right, it provides a snapshot of the crisis.
Exactly. So in this 2005 survey, they interviewed 910 homeless individuals. And the core question they asked was simple. What specifically caused your homelessness?
And the breakdown of those 910 responses perfectly validates the demographic split we discussed earlier.
Yeah.
The top cause, cited by 338 people, was the loss of a job. That was followed closely by could not afford housing, with 283 responses, and inability to pay rent, with 206.
Which perfectly aligns with the transitionally homeless category. The vast majority of these individuals aren't suffering from severe psychosis. They're simply priced out of survival in a hostile economy.
Exactly.
Other major causes cited were family disagreements with 170 responses and drug or alcohol problems with 150.
And when you look at the services these 910 people actively requested from the survey workers, it makes perfect sense. The highest requests were for help finding a job, help finding a place to live, transportation assistance, and basic case management.
Right. They're explicitly asking for the logistical tools of stability.
But hidden deep inside that survey data is a phenomenon that is deeply, deeply disturbing. It points to a massive mechanical failure in our public institutions.
Oh, the institutional discharge data.
Yes. Out of those 910 surveys, there were 66 people who explicitly stated that their homelessness was caused by release from an institution. We were talking about people being discharged directly onto the street from treatment clinics, from hospitals, or from county jails.
This is one of the most critical failure points in the entire American social safety net. It is known in the industry as discharge to homelessness.
Let's really analyze why this happens, specifically with the medical community, because the paper calls them out directly.
Okay.
Hospitals are literally putting highly vulnerable patients into taxis from the emergency department and instructing the driver to drop them off at the front door of a homeless shelter.
It's unbelievable. To understand the mechanics of why a hospital would do something so seemingly callous, you really have to look at how hospitals are incentivized. A hospital is designed and funded as an acute care facility. They exist to stabilize immediate medical emergencies. So if a homeless person comes in with severe pneumonia caused by sleeping in the freezing rain, the hospital will administer antibiotics. They will treat the pneumonia.
They fix the acute symptom.
Yes. But once the pneumonia is cured, the acute medical crisis is technically over. However, the hospital has no mechanism and no funding to cure the environmental cause of the pneumonia, which is the lack of housing.
Right.
And an acute care hospital bed might cost the facility $2,000 or $3,000 a night. Their insurance, if they have any, like Medicaid, stops paying the moment the acute phase is over. The hospital administration just cannot financially justify keeping a medically stable person in a $3,000 a night bed just because they have nowhere else to go.
So the hospital's liability ends, the funding ends, and they call a cab.
It reminds me of a terrible mechanic.
A mechanic.
Yeah, it's like a mechanic fixing your engine, getting it running perfectly, but then releasing your car onto a busy highway with absolutely no tires.
Wow. Yeah, that's apt.
Technically, the engine works. The acute problem is solved. But because of the environment they are releasing you into, a catastrophic crash is mathematically guaranteed. A hospital treats a medical emergency, stabilizes the fragile human being, and then hands them over to a taxi driver to dump them at a crowded overnight shelter that has absolutely zero medical equipment and no nursing staff.
It is a profound moral and systemic failure. When a massive multi-million-dollar institution which possesses incredible funding, legal power, and medical expertise discharges a vulnerable, recovering person to the street, they are essentially washing their hands of the systemic problem.
Yeah.
What Ben Graybass highlights in this paper is that local, faith-based missions are the ones violently forced to step into that void.
They become the safety net for the safety net.
Exactly. They end up providing what is known as respite care.
Yeah.
They're doing the grueling, complex post-medical recovery work, managing wound care, ensuring medication compliance, providing a clean environment for a weakened immune system that the heavily funded medical community has simply abandoned.
Which brings us to the actual frontline interventions. Because if massive federal and municipal institutions are literally dropping people off at the doorstep, we really need to look at who is actually opening the door.
We do.
We need to look at the legacy providers, the faith-based organizations that have been operating in this space for generations.
And the paper provides a very detailed operational look at one specific facility doing this work, the Rescue Mission of El Paso. They have been operating in that city since 1952.
1952. That is over 7 decades of institutional knowledge. They aren't just a soup kitchen handing out sandwiches. The paper highlights their highly specific modern innovations.
Like what?
Well, for instance, they run an intensive 13-week relapse prevention program that, at the time of the study, had recently graduated 33 individuals. But here's where it gets really interesting to me. It's how they fund and structure their intervention. They have a program explicitly called Homeless to Work.
This is a brilliant evolution of the traditional passive charity model.
Let's analyze how this actually functions because it's fascinating. They have residents at the facility building furniture.
Really?
Yeah, they literally manufacture physical furniture, which is then sold to other rescue missions across the country, to other nonprofits, and directly to the general public. And that single enterprise generated over $250,000 in revenue in a single year. That money goes directly back into funding the ministry.
The mechanics of why this works so well go far beyond the $250,000 in revenue, though. It's really about psychology and identity.
Explain that.
When a person is chronically homeless, society fundamentally treats them as a burden. They are constantly viewed as a consumer of resources. They consume shelter beds. They consume soup kitchen meals. They consume emergency room time.
Right.
The psychological weight of being perceived purely as a societal deficit is crushing.
You internalize that identity. You believe you are worthless.
Exactly. But the moment that person walks into the rescue mission workshop, picks up a hammer, and learns to build a solid oak table, the dynamic completely flips. They are no longer a consumer of charity. They have become a producer of value.
Wow.
They are creating a physical object that the public desires and is willing to pay for. The psychological shift from burden to creator is the actual primary intervention. The revenue from the furniture is just a highly beneficial byproduct.
It is an incredible entrepreneurial pivot. They are taking people who desperately need job skills, teaching them a tangible trade, restoring their dignity, and using the profits from that trade to fund the very shelter that houses them. It is a completely self-sustaining ecosystem of rehabilitation.
And while the rescue mission of El Paso is doing incredible modern entrepreneurial work, the author of our paper also wants us to understand the deep historical lineage of this specific kind of faith-based intervention.
Right.
To really understand the methodology, the paper takes us all the way back to 1852 in London, tracing the roots of the Salvation Army.
This brings us to William and Catherine Booth.
Right. William Booth was a Methodist minister with a burning desire to reach the absolute most destitute populations of Victorian London.
Okay.
But he quickly realized a fundamental flaw in the church structure of his day. He couldn't just wait inside a pristine building for the destitute to wander in. In 1865, he made a radical tactical shift. He started holding evangelistic meetings outdoors in the grimiest, most dangerous slums of the East End of London. He initiated direct, aggressive street outreach.
And the paper explicitly notes who his first converts were. They were thieves, they were prostitutes, they were gamblers, and severe drunkards. These were the exact people that polite 19th century Victorian society had completely discarded and deemed irredeemable.
And here is the crucial historical context that explains why organizations like the Salvation Army had to be built in the first place. The traditional established church structures of the time flatly rejected Booth's methods.
Really?
And more importantly, they rejected his converts. The respectable congregations simply did not want recovering thieves and prostitutes sitting in their refined pews.
Wow. So what did the Booths do?
They entirely bypassed the traditional church hierarchy. If the existing structures wouldn't welcome the outcasts, William and Catherine Booth decided to build a completely new structure explicitly designed for the outcasts.
That's amazing.
And we should note, Catherine Booth is rightfully recognized as a co-founder because of her massive pioneering role in shaping the theological and operational vision of the movement, particularly regarding the right of women to preach and lead.
Their approach was considered deeply radical for the 1860s.
It was revolutionary. And what is truly remarkable is the continuity. If you look at the Salvation Army Adult Rehabilitation Centers, the ARCs operating today in major cities all across the United States, you are looking at a direct, unbroken methodological line.
It's incredible.
It is a century and a half of consistent strategy. The philosophy remains exactly the same. You do not wait for the broken to come to you. You go to the people exactly where they are. You address their immediate, desperate, physical destitution, food, clothing, shelter. And through that physical care, you offer them a path to spiritual and social reintegration.
Okay, so through organizations like the Rescue Mission and the Salvation Army, we see the mechanics of how physical shelters operate. They were providing the roof, they're providing the meals, they're teaching job skills. In the context of our HUD discussion earlier, they are providing that third leg of the stool and part of the second.
Right.
But the paper spends a highly significant amount of time analyzing another organization entirely, an organization that doesn't build furniture or run soup kitchens, but instead provides the invisible psychological architecture of recovery. They almost exclusively address that vital first leg of our three-legged stool. Profound alcohol and drug addiction. We're talking about the unlikely giant of social intervention, Alcoholics Anonymous.
It is virtually impossible to overstate the impact of AA and its various offshoots on the modern crisis of homelessness. They are inextricably linked.
Let's look at the history the paper provides to understand how this massive network started. AA was founded in 1935, and it wasn't founded by a government committee or a massive hospital network.
No, not at all.
It was founded by a physician, Dr. Bob Smith, and a stock speculator, Bill Wilson. Two severe alcoholics who essentially realized through trial and error that the only way they could manage to stay sober themselves was by desperately trying to help other alcoholics stay sober.
And the foundational roots of AA are explicitly, undeniably faith-based, which is why Ben Gray Bass includes them in this specific paper. The source explains that both founders, prior to creating AA, were heavily involved in a Christian fellowship known as the Oxford Groups.
Right. The Oxford Groups were led by a man named Frank Bruckman. And their methodology was intense. They focus heavily on absolute honesty, rigorous public confession of sins, making direct restitution or amends to people you had harmed, and a mandate to help others live a Christian life in order to remove whatever barriers stood between the individual and God.
Those core principles, confession, restitution, and service to others, were lifted almost directly from the Oxford groups and became the absolute bedrock of what we now know as the 12 steps of Alcoholics Anonymous.
Okay, but I have to stop and push back here for a second because I am genuinely confused by the inclusion of AA in this specific academic context.
Okay, let's hear it.
We are analyzing a paper titled Faith-Based Programs and Their Influence on Homelessness. But anyone who knows anything about AA today knows that it is not strictly a religious organization. They explicitly do not require you to be a Christian.
Right.
They talk about a higher power, which they define as God as you understand him. You can be an atheist and be an AA. Furthermore, AA isn't a traditional program at all. They don't have a CEO. They don't have a massive lobbying budget in Washington. They don't build shelters. They don't distribute food. They don't even own the buildings they meet in. They just rent church basements and community center folding chairs for $2 a week.
That's true.
So why is this highly decentralized, fundamentally secularized fellowship occupying so much space in a discussion about faith-based interventions for the homeless?
This raises an incredibly important question, and the answer highlights what is arguably one of the most brilliant, life-saving structural decisions in the history of social intervention.
Oh, really?
Early on in their development, the founders of AA realized they were facing a critical juncture. They made a conscious, highly deliberate pivot away from strict religious orthodoxy. They explicitly decided to open their membership to anyone who had a desire to stop drinking.
Period.
Regardless of faith.
Right. Regardless of their specific theological faith, or even if they possess no faith at all.
But why? If their roots were so deeply embedded in the Christian Oxford groups and they believed that connection to God was the cure, why secularize the language? Why dilute the theology?
Because of the absolute life or death stakes of what they were dealing with. The paper notes their stark reasoning. If they demanded theological purity, if they turned a desperate, dying alcoholic away simply because that person didn't believe in the Christian concept of God, they knew they were actively consigning that person to an alcoholic death.
For the founders of AA, preserving the human life took absolute precedence over preserving the religious doctrine.
For pragmatism again.
Exactly. And that specific pivot, the intentional broadening of the higher power concept, is the exact mechanism that allowed AA to scale globally in a way no strict religious group ever could. Today, because they don't argue about theology, they span over 150 countries. They have over 2 million active members.
It is the ultimate decentralized, peer-driven safety net. Think about the mechanics of it. There are no membership dues. There are no intake fees. There are no insurance pre-authorizations required. There are no professional PhD-holding counselors running the meetings. It is entirely fueled by shared experience, strength, and hope among equals.
And because it is free and because it is available in almost every single city and town across the globe, it is the most accessible first leg of our three-legged stool imaginable. If a person loses their housing, falls out of the system, and ends up on the street due to a severe addiction relapse, they don't have to wait 6 months on a government waiting list to get help. They can walk into a free AA meeting or an NA meeting, Narcotics Anonymous, in any church basement in the country that very night and instantly tap into a global support network. It is an incredibly resilient structural safety net.
To ensure we don't get entirely lost in all this historical context, the policy debates, and the massive statistical data, the author does something really smart at the very end of the paper. They forcefully humanize the data.
Yeah, that's crucial.
They shift the focus entirely away from the macroeconomics and look at the actual specific human beings who are forced to navigate this incredibly complex, fragmented system.
Yes. The paper provides detailed case studies of 2 women, Patty K. and Alice C.
Let's walk through their actual experiences because their lives perfectly illustrate the mechanics of everything we've talked about today. First, we have Patty K. According to the case study, Patty was living on the streets battling a severe addiction to methadone. Her journey towards stability actually started when she sought temporary refuge at the rescue mission.
So her first point of contact is a faith-based intervention.
Right. But the rescue mission isn't a hospital, so from there, she was transferred to receive clinical detoxification at a publicly funded medical facility.
Now we see the handoff to government intervention.
Exactly. Once she was medically stabilized and the chemicals were out of her system, she enrolled in a peer-driven recovery center. Over time, she actually became a leader at that center.
That's awesome.
She became a member in good standing of Narcotics Anonymous, which, as we discussed, uses the exact same 12-step architecture as AA. And through that entire multi-stage process, she finally established self-sufficiency and was able to reestablish relationships with her estranged family.
Now, let's look at the mechanics of Alice C's journey. Alice was struggling with a highly destructive dual addiction to cocaine and alcohol. Her intervention didn't start at a shelter. It started with a judge in a courtroom.
The legal system forces the issue.
The judge essentially gave her an ultimatum regarding her behavior. Forced by the legal system, she enrolled in a peer-driven recovery program to address the addiction. Once she had achieved a baseline of sobriety and stability, once legs 1 and 2 were secured, she was able to move into a permanent supportive women's residence.
Okay.
And, crucially, that permanent housing was provided by the Sacred Heart Parish of the Catholic Church, a facility called Villa Maria.
So a faith-based organization provides permanent housing. They supply leg 3 of the stool.
Yes, and today, according to the study, Alice is a dedicated recovery advocate and a highly respected member of Alcoholics Anonymous, actively maintaining leg 1.
When I look at the trajectories of Patty and Alice, the most accurate analogy I can think of isn't a stool, it's a relay race.
A relay race, I like that.
Yeah, no single organization saved Patty. The rescue mission didn't do it alone. No single organization saved Alice. The judge didn't cure her. It required a massive, highly coordinated, sequential handoff of a fragile human life.
Right.
It was the legal system running their leg and handing the baton to the medical system. Medical system stabilizing the crisis and handing off to the faith-based shelter. The shelter providing the roof and handing off to the peer recovery network of NA or AA to rebuild the mind.
And that relay race analogy is the absolute perfect synthesis of Ben Graybest's entire argument in this paper. Because think about the mechanics of a relay race.
Yeah.
If any single runner in that chain drops the baton, the race is over.
Oh, wow. Yeah.
If the hospital, like we discussed earlier, puts the patient in a taxi instead of coordinating with a detox center, the baton is dropped. If the faith-based shelter has no beds because they lack funding, the baton is dropped. If there's no affordable, supportive housing available at the end of the line, the baton is dropped.
And when that baton hits the ground,
that individual falls right back into that chronically homeless 10% cohort we analyzed earlier. They go right back to the emergency room. They go right back to the concrete.
And the data presented in this paper clearly shows us that local faith-based organizations are very often acting as the anchor legs of this relay. They're the ones diving to catch the baton when the massive state institutions drop it, and they are the ones holding the line day after day while the individual slowly builds the capacity to cross the finish line into stability.
That is the core thesis.
Okay.
Bass is arguing, with deep statistical backing, that without the localized agility and tireless, granular work of these neighborhood ministries, the sweeping federal goals to end homelessness would be mathematically and logistically impossible.
Speaking of sweeping federal goals, we really need to contextualize the ambition of the era when this research was actually published. Remember, this paper came out in 2009.
Right.
And the paper outlines HUD's stated official federal goal at that specific time. Their objective was to end chronic homelessness entirely by the year 2014.
It was a massively ambitious target, driven by the new data regarding Housing First and the sheer cost savings of intervention.
And it wasn't just a federal pipe dream. The ambition cascaded down to the local level. The paper notes that in 2004, the mayor of El Paso, along with local service providers, signed onto a 10-year plan to literally eliminate long-term homelessness in their specific city.
Wow.
Their strategy was exactly the synthesis we've been discussing today, combining federally funded permanent supportive housing with the localized faith-based wraparound services to build that three-legged stool.
The pervasive belief at the time was that we finally had the data. By putting individuals with complex treatable issues into a supportive environment, and by heavily leaning on the existing tireless infrastructure of places like rescue missions and the Salvation Army, society could actually solve the root of the problem, rather than just endlessly, expensively managing the symptoms.
So what does this all mean for you, the listener, right now? We've spent this time unpacking the massive $300 billion shadow budget of American philanthropy. We've debated the intense psychological friction between HUD's continuum of care and housing first philosophies. We've done the math on the staggering $40,000 a year cost of institutional apathy versus the life-saving economics of permanent housing.
Yeah, we covered a lot.
And we've traced the evolution of frontline street work from 19th century Victorian London all the way to modern-day El Paso, Texas.
I think what it ultimately means is that our community safety net is simultaneously incredibly fragile, yet deeply, surprisingly resilient.
Yeah.
It is resilient entirely because of the humans on the ground. When the massive, clinical, well-funded gears of federal bureaucracy and medical systems grind to a halt, or when they fail to see the complex human being behind the diagnosis, it is the community-level, often faith-driven interventions that quietly step into the gap to catch the people falling through.
Which brings me to a final thought I want to leave you with today. This paper, written back in 2009, confidently documented 10-year municipal and federal plans explicitly designed to end chronic homelessness by the year 2014. Now, sitting here in the year 2026, 12 full years past that ambitious deadline, I want you to walk around your own city tomorrow. Really look at the encampments, look at the people sheltering near the overpasses. When you look at the reality of the streets today, ask yourself, did we fulfill the promise of those 10-year plans?
Tough question.
Or have we, as a collective society, simply accepted a deeply complex but ultimately solvable crisis as a permanent, immovable feature of modern American life? And if the latter is true, who exactly is going to build the next three-legged stool? Because right now, the systemic math is still broken, the institutional batons are still being dropped, and the people operating on the front lines are still waiting for the rest of us to decide if we actually want to fix the engine or if we are just going to keep paying for the taxes.